Welcome everyone, and thank you for joining another virtual presentation as a part of our 2021 Global Health Leaders Conference at Johns Hopkins University. Today, we are very happy to have Dr. Smisha Agarwal at our conference. To briefly introduce Dr. Agarwal, she is Research Director of the Johns Hopkins Global mHealth Initiative and an Assistant Professor in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. Her research is aimed at improving maternal and newborn health in low-income settings through strengthening community health systems and leveraging innovative solutions. Over the last decade, she has developed methods for evaluating programs that employ digital tools, such as mobile phones for health service delivery. Dr. Agarwal, thank you so much for being part of our conference. Feel free to begin your talk whenever you're ready.
Great, thank you, Sam, and appreciate, really looking forward to this talk, and thank you for inviting me. And also really great to have a few folks on video cameras. Always helps with the online medium to be able to see some faces, right? So great, I encourage you to stop or raise your hand and ask me questions as I get started. So feel free to raise your hands, and I'll try to pay attention and stop and try to address questions as we go. So today, maybe briefly to introduce what the Johns Hopkins Global mHealth Initiative is. It's a collaboration across the school of Johns Hopkins, across 35 plus faculty, with over 150 projects, all of which are focused largely on using innovative techniques, using digital tools to address healthcare issues. What that looks like, I'll get into shortly. We also support a wide network of students, interdisciplinary students who work across engineering and healthcare, and we support them through involving them in projects or through attending conferences and just becoming sort of more tuned into the work, into our daily work. So with that, what is mHealth? It used to be called mHealth Mobile Health, and more recently it's called what is digital health. So I will talk about that briefly, but first, why is mHealth or digital health an important way of addressing healthcare needs globally? It's really shown on this map here, right? So over the last decade, we've seen this inflation of a rapid rise in the number of telephone subscriptions globally. And if you look at this map, most of the increase has very much been in low and middle income countries. So this is India, and even in the African region, you see that there's been a rapid rise in mobile cellular phone subscriptions. And so just for a moment, imagine what this means. It means that in a setting not quite different from what you see in this picture, where individuals may not have access to clean drinking water or to electricity, they have a mobile phone, right? There may be no roads, no concrete roads that lead to these communities. Their way of accessing healthcare might be really challenging. They may not be able to actually travel to see a doctor, but they have a mobile phone, right? So what a fabulous opportunity as the public health field for us to really tap into those phones to see if we can use them as a way to strengthen and deliver healthcare services. What does that look like? It could look like a number of things. Mobile health is not just one thing. It can mean different things in different settings. So let's say it can serve the function of it can serve the function of education and awareness. So for a public health emergency, such as we've had with COVID, or for other emergencies that we might see, or even for routine communication of any healthcare issues. A simple text message that's sent to a large number of individuals, or that's targeted to a specific number of individuals, is one way to think about it. Also, mobile phones can serve a diagnostic and treatment purpose at the point of care. We know often that healthcare providers, whether it's doctors, nurses, or lay healthcare providers may not have the knowledge or the training that they need to be able to perform their duties. And an app which has loaded onto a mobile phone, which has the diagnostic criteria, which has some treatment protocols, is able to walk the provider through what that might look like for the provider. And so let's say, for example, in the case of COVID-19, so you'll hear a lot of COVID-19 examples since that's the world we've been living in. But in the case of COVID-19, as the protocols for treatment and the evidence continued to change, it was very challenging for healthcare providers to keep up with the latest and the most up-to-date evidence-based practices. But having an app that they update that guides them through it might be one way to support diagnostic and treatment at the point of care diagnosis and treatment. Disease and epidemic outbreak tracking. So how about with a show of hands, I'm going to ask you to tell me if you downloaded any contact tracing apps where you report fevers or any COVID-19 symptoms. All right, so that's at the simplest, right? That's an example of disease and epidemic outbreak tracking. We figure out who has symptoms and we figure out who they've been around, and we're able to track an outbreak essentially by using GPS data. It is problematic. It has a lot of potential safety, security, privacy issues, but it's definitely an option in some settings. Supply chain management, that is a more complicated type of intervention that maybe it'll help start with, in many settings, we do not have enough drugs and supplies, right? So a patient may go to a healthcare provider hoping for maybe something simple, maybe the appropriate treatment would involve antibiotics, but the healthcare facility has run out of antibiotics. And this is quite a typical experience for much of the world's population because the supply chain management systems are really not developed. And so mobile phones are one way in which we can track supplies and we can report. So for example, well, there are two issues. So there may not be enough supplies, or the supplies might be counterfeit because somebody's taking advantage of the market and they're packaging, let's say, sodium bicarbonate instead of a white, instead of a white capsule or a white drug. And so by scanning a barcode, you can actually check for counterfeit medicine, and by healthcare workers can report using their mobile phones the stock levels at their facility, which can set off sort of a management chain to facilitate supply chain management. There are opportunities for remote data collection, which I think we've all experienced. We've been on the user end of it too, since we've been donating our data for COVID-19 research, let's say. For remote monitoring, which definitely something else that I think several of us may have experienced in the US healthcare setting, where you might be wearing sensors or other monitors that capture data that are shared with your healthcare provider, or maybe it's our families who would share routine measurements of blood pressure or diabetes with their healthcare provider. And then finally, healthcare worker communication and training. And that's similar to where healthcare workers may not have adequate access to training, and they can have training modules sent to their mobile phones where they can complete the modules as a form of continued education. So that's different from a point of care decision support. So I'll maybe take a moment there. This is just some examples of digital health interventions. There's a wide variety more. There are other classifications of what some of the common applications of digital tools are. I'm not covering all of them. Are there any questions or clarifications? Amanda?
Can you elaborate on how mobile phones can be used as a point of care device and what point of care devices are?
Yeah, absolutely. So I have a little case study coming up with it. So I will, yeah, Absolutely. So I'll get into that. Others? Yuli, is your hand up from before or is it freshly up?
Oh yeah, I had a question. Thank you for being here today. I was wondering what are some of you mentioned that there were a lot of privacy issues that could be encountered using mobile health. I was wondering what some common privacy issues that you might run into are.
Yeah, so it's not necessarily using mobile health, but using certain applications, right? So I mentioned privacy issues, especially where we are sharing our data and our GPS location with a government body. So for example, over here, we live in there's a democratic government. There are other governments that are more autocratic, where they can really sort of restrict the movement of their citizens if they know their GPS location, or they may more forcefully implement, let's say, COVID-19 restrictions. Over here, often COVID-19 recommendations are made, right, for restriction of movement. For example, if you test positive or if you've been exposed, if you're a contact, but they're not enforced. You will not go to jail if you break them, right? There are other places where if your identity and your location is known, you can go to jail for breaking, or you can be, you can face legal ramifications. So that's sort of the more immediate COVID-19 example that comes to mind. But there are also other privacy issues. Your personal information, maybe your medical information that is shared to these platforms. If there's not adequate sort of sense of privacy and security, then that is at risk. Telecom operators, they monitor every movement. Actually, we use data from telecom operators to study population level movement during COVID-19 to try to understand whether movement whether there was a specific kind of movement that was restricted during the lockdowns. And let's say we ask for movement of individuals in this town with a population of 30,000 or with a population of 300 people, right? Can I take that movement information with any personal identifiers and actually figure out who the individual is? I can. And so that's another security risk. But so telecom providers will actually have rules in place where they cannot give you information at that level because of the risk that it poses to security. So lots and lots of security and privacy considerations, I think, but that's not to discourage you from sharing your data through these apps. I think that's great and a responsible thing to do.
Okay, thank you. Sorry, I had one more question from your response. So you mentioned that some governments might be more strict on these kinds of data that they allow people to release. So what are some ways that, if there are ways that people have gone around some of these restrictions in order to provide healthcare to people who are in need but are in a government where they can't access certain healthcare features because of the restrictions placed on them?
Sorry, so the restrictions are placed to enforce quarantining, right? So
I see.
So it's not to restrict healthcare access, but it's to enforce quarantining. Whereas in the US, it's recommended that you quarantine, but there will, a guard will not be posted at your door, right? So, but in other places, a guard will be posted at your door to ensure that you quarantine. So just a slight distinction. And it's not to critique a culture. There's a lot of cultural sort of context and understanding, as well as healthcare context and understanding that I think is important. So we shouldn't automatically assume that that's a bad way to, implement healthcare precautions.
Okay, thank you.
Okay, so moving on to how I started thinking about digital health. It was several years ago where I was working in a village in rural India, and on my first year of work, I was presented with this is just a sort of a microcosm of what I was presented, but it was a room full of these stacks of paper, right? And they said, can you digitize it? What are these papers? They are healthcare records. And so what happens is, and they are healthcare records from 4 decades. So it was a large room that was stacked floor to ceiling with these healthcare records about a community of about 60 villages. And so what used to happen is, so this woman here is a community health worker, and a community health worker is typically, in the case of India, a lay village person who has received some training to provide basic care services to their community. In this case, they were taught to care for pregnant women. And they went door to door in the community to check on the pregnant women. They measured their blood pressure, their fetal position. They checked on, if there's everything's going right. And they were just taking down sort of bare parameters of health. And they were making note of it in their notebook here by name. And then every week they would come to a central facility where a senior supervisor would transfer that data onto a central database from across many healthcare workers, right? So they're consolidating the data. And hopefully this data would actually be used or digitized so that somebody is using it for clinical decision making. Ideally, we'd like to say, oh, well, this woman has high blood pressure. She might be at a risk for preeclampsia or some complications, and let's monitor her more closely, or let's bring her to a health facility, right? But that did not often happen because we're not digitizing this data, and so we're not able to actually see if the patient is at higher risk. And so when I was a young, fresh graduate student, when I was faced with this challenge, and I trained several data entry folks to start entering the data into the computer system. And over the next month, I tried, and each time there were barriers. There were viruses, we lost data, there were electricity outages, so that people didn't save or back up the data, and so the data disappeared at the end of the day. And then finally, this is an agrarian community, so they depend on agriculture, their livelihood. Finally, when we thought we had a system down for maintaining and backing up data, the prices of onions in the market nationally went up. There was an onion shortage, vegetable onion, right? And so all the data collectors left, and they went to the field to plow. And so not what we think about, right? Practically, it's not what you're taught at school. You can't manage the prices of onions nationally. But that's what happened. And so I lost the entire data collection staff. And it was a good sort of practical first lesson in figuring out how to actually implement public health in practice, right? Not the rosy picture you hear about in classrooms. And so we started this organization called Global Health Bridge. What I noticed then was that even in these villages, people were using their mobile phones to listen to cricket updates. They were not literate, they could not read, but they understood numbers. And so they could use IVR, interactive voice response system, which says, press 1 to listen to updates from this match, or press 2 to listen to these updates, and press 3 to repeat the updates, right? So, but they could do that to listen to cricket updates. And so we created a system where instead of taking that notebook and writing the information and then coming to a center and transferring the information and then me trying to manually enter the information, where healthcare providers were trained to use their phone. And it is a guided algorithm that tells them what to ask the woman. They enter the information on their phone, and the data are immediately uploaded to a server where it's automatically digitized and sitting wherever doctors and nurses and clinicians can actually see the data, and they can link the data to a specific pregnant woman. So that was sort of the disruptive solution that we identified to that problem. And so, Amanda, to your question of clinical decision support, here we go. One example of where clinical decision support, a point of care, diagnostic, and treatment might be relevant. There was a recent Lancet report. So Lancet is a celebrated peer-reviewed journal. There was a recent Lancet report that one of the biggest killers is low quality healthcare.
And why do we have low quality healthcare? There are many reasons, but some of the reasons have to do with the skills of the providers. In several, especially low and middle income countries, and especially in rural areas, even in the United States, there is a shortage of healthcare workers, right? Estimated at about 12.9 million healthcare workers by 2035. And so there are healthcare workers who have fewer skills who are doing the job. And so the example I provided you of community health workers is one such example where the healthcare workers, they're trained to provide prenatal services, right? But ideally that should be provided by a nurse or a midwife or a doctor. But there's a lower sort of skilled healthcare provider who's doing that job, and that results in shortage of quality. Second, the doctors might see, or healthcare providers might have very large volume of patients, so they cannot provide comprehensive treatment. And third, there is a no-do gap, right? Even if they know it, in a rush or in their current state, providers may not do what they, do everything that we know. And so that results in lack of quality of healthcare services. And that's where mobile clinical decision support systems come into play. So they, at their simplest, they are algorithms that use if-then rules based on evidence-based clinical protocols. They might be checklists, and they might be sort of step-by-step guidance to screen clients. What does that look like? I'll present an example of a case study in Tanzania that we did in collaboration with a number of different organizations, where we built a job aid to support community-based family planning counseling. So we wanted to help women find the right contraceptive for them, right? And this was an area with a high prevalence of HIV. And so we wanted to ensure that the family planning method that they employ is also responsive to their to any needs they might have or any exposure they might have to STDs. So we developed these protocols that were structured as apps essentially on mobile phones. So for example, this is the protocol for registration and counseling, where a healthcare provider goes to a woman and a form is downloaded onto the healthcare provider's phone. She asks the woman, are you currently using a contraceptive? Yes or no. Would you like to use a contraceptive? Yes or no. And if she does want to use a contraceptive, she does pregnancy screening to make sure the woman's not pregnant. And she talks about the various types of contraceptives, talks about their benefits or their drawbacks, side effects, screens for HIV. And so this is a step-by-step algorithm that the app that's downloaded on the phone guides the healthcare worker at the point of care. So as she's talking to the woman, she's entering the information on the mobile tool, and based on the information that's entered, the form is posing the next question essentially, right? So if she says no, then let's say she says, would you like family planning services? And the woman responds no, it goes to another form and it says, well, are you satisfied with your contraceptive method? And so it changes directions based on what the woman says. This is another sort of example of that protocol that we use. And the way that looks like in practice is that the community health worker asks the woman about their family planning needs. As she's offering services to the woman, she's also entering data about the client into the mobile phone form. And the data trigger off an appropriate algorithm, directs them to questions about family planning or HIV or STDs. And these data are immediately uploaded onto a server. We can see it in real time. Along with the data, there are also little nuggets of knowledge that the form provides, or that the form uploads, that the healthcare worker can share with the client. And based on all of this data, let's say the woman chooses one method, so chooses pills as a contraceptive method. The healthcare worker can give her a 30-day supply, and it sets up a trigger to remind the healthcare worker to go back to that woman after 30 days to ask her, did the pill work well for you? Do you need to change, and so on? So that's one way of providing clinical decision forth. In the US, such systems are also routinely used, but mostly for chronic disease and more sort of complicated. And they might have integrated systems for measuring sort of the dosage, let's say, of certain drugs, or they may do a risk assessment. So for example, at Hopkins, there is a team that's based on individuals' risk profile, based on individuals' health status and age and other parameters, builds a COVID risk score, right? And so the provider will enter information about the patients, and based on that, there is guidance on COVID risk. So similar sort of idea. And these are new strategies. And so we want to understand if they are feasible, if they're efficient. We cannot assume that the mobile phone will work perfectly in a peri-urban or a rural place in Tanzania, right? So we want to assess its feasibility. We want to assess whether these healthcare workers may or may not have had any exposure to a mobile tool. And so are they taking too long? Is it distracting from the patient provider experience? So in the US, that's often a concern, where providers are staring at their computer as they're talking to the patient, right? And the patient feels like they can't connect with their providers. It actually disrupts the quality of care, not enhances it. So there was a study built around it, and we were actually able to track the service utilization data at each step. And if you're interested, these are some studies that were published that tell you a little bit more about the intervention, and it has a detailed protocol around it. So let me skip over that. Let me give you another example of a different type of an intervention. So this is a mass communication intervention. In several settings, young people cannot ask a healthcare provider for information about contraceptives because sex is taboo, right? And so, but a mobile intervention, especially as young people do have mobile tools, is one way to address that. So we had, this was implemented in Kenya, Tanzania, and then it was also scaled across to several other countries with several million users. And so it's a SMS health communication program where you'll see large billboards for contraceptive information, message M4RH to 2212, for example, right? And when you message M4RH to 2212, you get a message back saying, welcome to the service. If you want to get more information about this, reply with this, and provides a list of sort of contraceptive options to individuals. So they have the opportunity to learn more about it through this system. And so it's just back and forth, right? And where we've probably done this for, in our context, for shopping or for some kind of a tele or marketing. So it's a similar system, but for healthcare. And so a system like that, I think when we implemented it quite a while ago, for a decade ago in Tanzania, we had over 2 million hits within 2 months. So that was the express need of how many people felt like they didn't have access to such information and would benefit from it. I should, I haven't sort of discussed the limitations or challenges of it, but SMS in those settings is a very expensive medium. Most people use WhatsApp, but data too are expensive and available to some. So there are also barriers to such a system unless you can comp it. About 10 years ago, we could get free services from telecom operators, but those are much harder to get now. So we worked
about the previous slide. Why are these services harder to get now rather than 10 years ago if technology seems to have gotten better?
Yeah, so I think 10 years ago, we were just able to strike deals with telecom operators, and they saw it as a way to disrupt the market, to get more consumers, to use this as a value-added service so they can grow their business. But for them to grow their business, they need tens of millions of individuals. So a 2 million subscribership is still a drop in the ocean for them. And so they realized that working with the public health sector was probably not the best use of their free dollars I think, ultimately, because we don't work with such large volumes. So at least we haven't figured out the best way to work with such large volumes of individuals, unless it's a government campaign. So it is still possible to get such collaborations, but they're just a lot more challenging unless it's a government partnership or there is some guarantee of a subscribership.
I have a question also. Is there an issue with confidentiality? Is there any way for example, teenagers seeking information and parents to see the cell phone data or the bill and have their privacy breached that way?
Yeah, absolutely. And I think those issues haven't been studied enough. We know so we recently wrapped up a series of reviews for the WHO, because the WHO developed guidelines for digital health. And we were looking for unintended consequences. So, something like what you described. And what we did see is that in women who were HIV positive and were using such services, they experienced they reported more violence at home. And we believe that is due to breach of confidentiality. And so, but there isn't enough, there isn't enough documented evidence, unfortunately, because these incidents do occur, but they're probably not as easy to document or as many in number. And I believe even for there is some documented evidence where public health professionals have worked with sex workers, because one of the challenges of mobile phones has been that typically any kind of sex work was attached to a physical location, right? But now with mobile tools, they're more mobile, and any interventions that is targeted at sex work, especially if it's using GPS location, can make those populations vulnerable to legal action, for example. So there are privacy and security risks at each of these. That's one potential for the users. So all right, I'm moving on to the last sort of segment of my presentation today, which is really sort of transitioning from these health systems-based interventions to a different type of intervention. And that's really one of the reasons is that we see sort of this rapid urbanization and demographic shift to a younger population in sub-Saharan Africa. And so what that sort of changes for us is, so till now, in working with these mobile devices, we have always struggled with issues of literacy, right? And of not just of language literacy, but also of technical literacy. We know that we're excluding some people. We know, for example, that in certain contexts, individuals over 45 are less likely to adopt a digital intervention because they're not as tech savvy, or they may have more limited ability to read. But we're rapidly seeing a change in that. And so what we're also seeing is that there is rapid migration to mobile broadband capabilities. And so data packages and 3G capabilities are becoming a lot less expensive. And so previously, especially in low-income settings, we were more interested in setting up systems that did not require data. But now we expect that in the next 5 years, data packages will be available at a lower cost, right? Another trend and not only at a lower cost, but also amongst rural populations, which until now has been a limitation. And another trend we're seeing is that everybody uses Google for their health information, right? Individuals, and this isn't limited to low or middle income settings, but individuals may spend 4 minutes with their doctors, but they'll spend 4 weeks online diagnosing themselves and figuring out how to treat themselves. And that's the truth, even in sub-Saharan Africa. So in a survey conducted by Pew Research Center across 6 sub-Saharan African countries, suggested that in the last 12 months, about
41% of the respondents had used their mobile phones to get information about health and medicine. So that is huge. And so we are seeing this transition. And I think increasingly we need to figure out how to grapple with and how to control this online space. So we are truly transforming the healthcare experience of individuals. In several settings and I think the more recent sort of emphasis has been on person-centered care. Much of the care that's organized, even in the US, is not person-centered. It's not built to support the individual. It's built to support the healthcare provider or the healthcare system or the insurance companies. And so how do we take that in whatever context and build the system to support the individual? The simplest, maybe the low-hanging fruit of thinking about person-centered care is we always want to talk to youth about, let's say, safe sex. But what they often want to know about is good sex, right? And the safety is a parameter, but it is a less important parameter. But because of the setting or the culture that we might work in, the care is not person-centered, right? And so that's sort of a taboo area. So we don't want to talk about it. Let's say in more complex healthcare settings where, so for certain cultures, babies might be kept next to the mother in a certain way. But when they go to a healthcare facility, the baby might be kept separately. And that's not their culture. It's not the healthcare services is not centered around the individual. And so information, more often than not, is not centered around the individual's needs. And that's why individuals go online to look for information, essentially. However, with the online space, there are concerns about the quality. There are concerns about the quality of information. Right. So while the online space provides a safe space, it fills critical knowledge gaps, and often through various sort of chat rooms and so on, can provide social support. It can also provide misinformation. It can be risky because there's a lot of lack of validated information or guidance by a trained provider. And then there are concerns related to privacy and confidentiality. And so an area that I've been working on are conversational agents or chatbots or health bots for help. And so those are systems that mimic human conversations using text to spoken language. They are used, I'm sure that most of us today have used chatbots in some shape or form, maybe for shopping or for ordering pizza or for booking a travel a trip somewhere. And what we see is that even in low-income contexts, these bots are becoming relevant. In fact, the WHO implemented a bot for COVID-19 that had over tens of millions of users. I missed an exact number. And so health bots are often focused on health literacy. There are a number of health bots that are focused on mental health, depression, anxiety. On the right, you see one example of it. I encourage you to download Visa if you'd like to experience sort of what a bot delivered service might look like. And so these are some of the areas that health bots have more recently addressed. And increasingly, there is some evidence that using a chatbot or the use of a chatbot by individuals can have positive effects on symptoms of depression and anxiety. It's also, there is a bot that was recently evaluated called Gabby that showed decreased preconception risk amongst Black women, and also positive effects on literacy and sexual health and substance abuse prevalence amongst adolescents. So some of the bots are listed here. And so some of the bots might just be sort of a ping pong back and forth, but others might have a persona, might have an avatar, and so on. So there is a little bit more of that engagement. The area that I have been working on with computer scientists at the Whiting School of Engineering is figuring out how we can implement natural language processing with these chatbots. So typically chatbots, they follow an algorithm, if this, then that, right? If A, then B. But in order to make information truly user-centric, we want the information to respond to user needs. And we are trying to see if we can embed natural language processing databases to sort of power these bots so that it understands, the bot understands user language and is able to respond to the user with the most appropriate set of information. And so here's one example of the WHO bot that I mentioned. Let's see, this is supposed to play. So is COVID going to go away? But the WHO bot says, press 1 for this, 2 for that, 1 to 7, right? And when we ask it a question, it just gives us an irrelevant answer because it's algorithmic. But what we attempt to do with this is the Hopkins COVID-19 bot, and let's see if this plays. So let's see, we ask it a question. The same question, is COVID going to go away? We use natural language to ask the question. Is it going to go away in summer? Okay. And it says yes. I can tell you more about will warm weather stop COVID. So we asked, is COVID-19 going to go away in summer? It interprets it, it maps it to its database, will warm weather stop the COVID-19 outbreak, and it provides a relevant answer. And so that's centered the information around the user. In the absence of such information, the user might go onto Twitter or onto Facebook, where they might hear that they should drink some kind of chlorine or bleach to actually make COVID go away, right? So that's the difference. And so by centering the information around the user, we're able to lower the risk that the user faces because they're actually able to get the information that they need. Right, so some stats about the bot, and another example that we piloted with some collaborators in Uganda, where, and this was using Facebook Messenger, and it was focused on primary healthcare. So individuals could go through Facebook Messenger to this bot, and they could select a chief complaint, and the bot would ask them a series of questions, and the bot would calculate a triage score. Based on the acuity of the symptoms, the bot would provide home care advice or to see a doctor or to go to an emergency room. And if the symptom acuity was high, the bot would provide a callback option to the telemedicine center, so to speak to a human. So what it's done is taken this large volume of users who have questions and triaged users that say, well, I have a headache and maybe I sneezed a little bit, right? And it's provided them with some home care advice and then triaged them and escalated those who actually might be presenting with a severe symptom to a healthcare provider. And so this is what Mirembe, the bot, looks like. It's asking a series of questions. You go down, do you have any other symptoms? And it's giving sort of a temperature check. You're a bit in the yellow, and so maybe you should not try home care, but if symptoms escalate, call a healthcare provider, providing some guidance. So we're just in the process of building these bots, and I anticipate that it's going to take the next several years to actually get them right. The information that we used to power the bot is from a US healthcare context. It's not set up for Ugandan English. And so we realized that a lot of the symptoms were not recognized. Actually, 58% of the users had their symptoms recognized. That means 42% of the users did not have their symptoms recognized. And the reasons for non-recognition was spelling errors, use of slang, and just a mix of English with local languages. And so we are working on building databases that are actually set up for non-American or British English contexts that can be used, as well as in colloquial languages and other non-English languages. In order to build these databases, we're also mining data from various online spaces, and this is one example of like some Reddit boards that we've been mining data from. And the process is that we use that data to identify topics and to build content around those topics and program them so that they can actually work with the bot. Some details for the aspiring computer scientists here of the methodologies that we're using to sort of power the topic identification and the use of large data to build these topics. And it really gives us something like that. It shows us, what are some of the topics that are being discussed more on these hub boards. And so in terms of developing our database, we can prioritize what to develop the database, what to include in the database to power the bot. I think I can actually stop there and ask if there are any questions. I know I only have about 10 more minutes, but that's my last slide. So I welcome any questions you might have.
Thanks so much for the excellent presentation, Dr. Agarwal. Yes, students, if you do have questions, please use the raise hand function. Just let Dr. Agarwal know what grade you're in and where you're from. And yes, we can take questions for about 10 minutes. Feel free to also put your questions in the chat if you're unable to use your camera and mic. First, we can go to a question in the chat. It is, how do you ensure that the data you mine from message boards is usable / accurate? Is there a screening process?
The data we mine from these boards is often not usable and most often not accurate. And so we train models. We don't manually go through them. We train models to interpret and read them. And then we might add some manual checks where if we find a consistent inaccuracy or if we find a consistent accuracy, we'll label that so that that provides a guide for others. But we use machine learning models to actually be able to do the work. We don't physically look through the data ourselves.
Thank you. Next, we can go to Naharan.
Hello, thank you so much for your presentation. I enjoyed it. So I have two questions. The first one being, how can we make chatbots more accessible to people with disabilities, such as blindness or if they're deaf?
Yeah, so it's still actually relatively an emerging field, and that's a great question. So a lot of these apps are, there's an increasing push that they are built for individuals with disabilities. We haven't necessarily figured out the best way to do it. So if you think about Alexa or Siri and how sensitive Siri is, it takes sort of setting Siri up for healthcare use, let's say for blindness. So individuals, so they are voice activated, right? Instead of requiring sort of a screen. But I think that's definitely being thought about in the US and more sort of developed country settings, and there's still a long way to go in several other settings.
Thank you. Next, we can go to Ishana.
Hi, sorry I'm unable to unmute. Thank you for the presentation. I think earlier you mentioned that there will be a global shortage of healthcare workers by 2035. So I just wanted to know, how do you think this will impact rural areas in particular? And do you think that there's been a shift in doctors going to the private sector in particular? And do you think that has impacted how we've been able to globalize medical know-how to some extent?
Yeah, great question. So there is already a shortage of healthcare workers, especially in rural areas, and some of the predictions for 2035 are based on modeling estimates, because we know that healthcare providers tend to gravitate towards urban areas where they have the resources to start families and go to schools. And so I think a lot of governments are paying attention to that and are taking the necessary steps to make rural postings more appealing to healthcare providers, or providing advanced benefits. If you think about even the US, several rural counties in the US provide healthcare providers with larger pay packages, better benefits to attract them, especially if they're looking at specialists that several rural areas may not have access to. So I think the predictions or the modeling estimates are an estimate if we continue as we are, but hopefully we will take the steps to at least decrease the impact of the anticipated shortage. Yeah, but I should mention that the shortage exists as of now, right? Which is why we train community healthcare workers to fill in the gaps often.
Okay, thank you so much.
Next, we have a question from Nirali in the chat. She asked, do you think that with AI developments, chatbots could maybe diagnose users with symptoms without callbacks and telemedical professionals in the future?
I think I don't believe they should. I think human health will always be a little bit more complicated than what can be automated. There will be certain conditions that could be diagnosed using chatbots and using symptoms alone, but we know that to actually diagnose anything more substantive requires tests and requires palpation, requires sort of physical touch. Requires an understanding of the person, requires an understanding of their environment, right? And so I see the role of chatbots in triage and in perhaps even addressing some challenges in settings where there is mass shortage, but not. I hope that we don't make our healthcare completely robotic. That's not the goal. These are intended to be adjuvants to care, but I don't think they're intended to replace personal care.
Thank you. And you sort of answered it already, but Charlie is asking, are you worried that users will become too dependent on chatbots and mobile advice and thus increasing the risk of misinformation and disorientation in maternal health care, for example?
It's definitely a possibility, right? I am more hopeful than that, but we definitely see studies of youth use of social media and sort of excessive social support through social media and how that negatively influences their mental well-being or their ability to interact socially in person. So I think those are real concerns. I doubt that healthcare is what's going to stimulate it. I think it's going to be social interaction that's likely to affect it more.
Thank you. And then if we have any other questions from students, we have a couple more minutes left. Otherwise, we can wrap up. Feel free to raise your hand. Okay, Amanda, you can go ahead.
How has Global Health Bridge changed since you first developed it, or is it still in use today?
No, it's not in use today. We actually closed down Global Health Bridge a few years later because we were using IVR technology, interactive voice response technology, which is a voice call. And in our initial assessment, we realized that at that point, that wasn't a technology that was likely to be scaled because of the expenses associated with it. But I think we were actually too advanced for our times because 8 years later, IVR is very much used and very much more cost effective. And so it is a viable approach, but it wasn't a viable approach in 2008 when we were working with it.
Thank you. And then we'll have our last question from Nahar again.
Hello. So one more question. When you showed us the sort of yes or no map for screening, for example, the one that was asking women if they were satisfied with their birth control, what about certain health questions that are not as yes or no, but more open-ended? How can we incorporate it in those screening processes, but still make it simple enough for people to use?
So I think the response can be more nuanced, right? So, for example, the client might say, "No, I'm not satisfied," and the healthcare worker might ask why, And they'd say, well, it makes me feel a little bit dizzy, let's say. And, and maybe they have a story around it. But really what the healthcare worker is doing is, let me suggest another contraceptive that might work for you. So there are sort of ways to incorporate the response without, or making decisions. There is still the human element, right, to this. And so there is the ability to take the response, which is often a narrative. I can tell you from working in community-based settings, it's never when you sit down with somebody in the community, they tell you a story. They don't tell you, they don't say yes or no. And so you are really picking the relevant information from that to like fit into the algorithm.
Students, thank you so much for the questions. Dr. Agarwal, thank you so much for taking the time to speak at our conference. There are many thank you messages for you in the meeting chat. We appreciate all you and your team do, and we wish you the very best.
Great. Thank you everyone for joining late in the day. An absolute pleasure, and I wish you a lot of luck in your public health careers. So.